Welcome to Lurie Children's Facebook Live. Today we'll be talking about single ventricle physiology and the Single Ventricle Center of Excellence here at Lurie Children's with Dr. Kiona Allen and advanced practice nurse Michelle Steltzer. Okay, let's get started, guys. So what is single ventricle physiology and how does that differ from a healthy heart?
So the normal heart has 4 major chambers. It has 2 top chambers and 2 bottom chambers. The top chambers accept blood and the bottom chambers pump the blood out. In most of our patients with single ventricle physiology, what we mean is that there's really only one functional pumping chamber. So instead of 4 chambers of the heart, they usually essentially have 3. And that makes us have to do a series of surgeries to help set up a circulation that will work for them throughout their lifetime. And so that there's a variety of different conditions that can cause single ventricle physiology. It's not just one diagnosis. There's many. You can have a single left side pumping chamber or a single right side pumping chamber or a single pumping chamber that we have trouble figuring out if it was the left or the right side. But in all of those conditions, the end anatomy is the same, where that one pump has to do the work of 2.
And so single ventricle physiology is considered a congenital heart defect?
Correct, yes.
What is a congenital heart defect?
So it's something that, we don't know the cause for it, but it's something that was, it happened in, throughout the baby's fetal life, and it can evolve over time. And it is a defect in the ventricle not being fully formed, the valves not being formed, the different vessels that can be not formed correctly. It can be any number of combination of things, and we won't know until the baby's first echo after birth.
Congenital heart defects actually are the most common kind of birth defect. It's found in almost 1% of babies that are born. There's a huge spectrum of how serious it can be, obviously. That can range from just a tiny hole in the heart that doesn't need anything done about it, that a cardiologist just follows throughout their lifetime, to as severe as a single ventricle heart defect, which is obviously much more rare. But at a center like Lurie Children's that does high-level heart surgery and has a whole team of professionals that deal with this kind of condition, we have a lot of children that we follow with pretty severe congenital heart defects that they were born with.
And so what are some of the single ventricle congenital heart defects that you treat at the Center of Excellence?
So it ranges, as I was saying, from ones that affect the left side of the heart to ones that affect the right side of the heart. So some of the common conditions that people might have heard of are things like tricuspid atresia or hypoplastic left heart syndrome. It's actually, there's a lot of different labels for things, but there are actually a whole almost infinite number of combinations of things that can be malformed inside the heart, and so sometimes we don't have a great name for what the condition is, and we just sort of have to describe what we see. So tricuspid atresia and hypoplastic left heart syndrome are the 2 sort of prototypical types. Tricuspid atresia is where the valve on the right side doesn't form, and the right side...
Maybe point it out.
Yeah. So there's a top chamber here on the right side. There's a valve. This is in a typical heart. The blood from the body comes back to the top chamber on the right side, which is called the right atrium. That blood is oxygen poor blood because the body, we're all aerobic animals, so the body uses up oxygen, and that's what cells use to do their work. So once the cells and the organs and the tissues have used up that oxygen, it comes back to the right side of the heart in the right atrium. It goes across a valve, this valve here called the tricuspid valve, and into the right ventricle. And from there it gets pumped out the pulmonary artery, which through a valve called the pulmonary valve, it goes to the pulmonary artery, and that leads to the lungs where the blood picks up oxygen. Once it's picked up oxygen, it comes back to the left side of the heart, into the left atrium, which is the top chamber on the left side, over here in the back. And then it goes across a valve called the mitral valve and into the left ventricle. And from there, it's pumped out the aorta across the aortic valve. The aorta is the big blood vessel that carries oxygen-rich blood to the body and to all the organs that need blood. So that's the 4 chambers in a typical heart. In tricuspid atresia, this tricuspid valve here never formed. It's just sort of like an a plate, so nothing can go across it. And so blood that comes back to the right side of the heart, instead of going across the tricuspid valve, it has to go across a hole in the top chambers called either a patent foramen ovale or an atrial septal defect to the left side of the heart, and then it goes down into across the mitral valve into the left ventricle, and from there it gets pumped out to the body. So the right side ventricle is either missing or is very small and can't really do many times the work that the body needs. And so in this case, the single left ventricle is doing the work of both pumping chambers. In hypoplastic left heart syndrome, it's essentially the opposite, where the mitral valve, the valve on the left side, doesn't form properly. It can either be small or missing, and so the left side pumping chamber is very small and can't do the work that the body normally would require it to, and so the right side pumping chamber has to do the work for both sides. We don't know in either of those two conditions, there's not a clear genetic background to them. It's usually something that, while congenital heart disease can run in families, it's not usually that there's multiple people in the family with either of those conditions. But we think there's probably something that we're just not quite smart enough yet to understand that happens in your genes that sort of makes this form this way in fetal life. And so all of our job after babies are born are to figure out how to make this work, just having one pump.
So let's talk about your roles. You see patients in the Single Ventricle Center of Excellence here at Lurie Children's. Tell us a little more about the center, how it's unique, and your roles in patient care.
So I am the program coordinator for the Single Ventricle Center of Excellence, and I'm the nurse practitioner that sees families from prenatal diagnosis if they were prenatally diagnosed, and I will see them throughout their spectrum. When the baby is born, I will see them in the ICU and sort of follow them and transition them to the heart clinic after the babies are ready to go home. And we'll also follow along closely with their pediatrician, with the referred cardiologist if there is anybody, and then they can transition to the what we call the big kid single ventricle clinic, which is for kids that have had the Fontan, the last surgery in the series of 3 surgeries to monitor for consequences of the Fontan physiology.
Kiona?
I think the really cool thing about our program is that we've sort of started to streamline the care of these kids who more and more of them are being diagnosed prenatally, although not all. And so I think it's nice for people to have a set of faces that they see from very early on in their diagnosis throughout their time in the inpatient stay and their outpatient care. I think that's part of why we make such a good team, because my other role apart from this is to be a physician in the cardiac intensive care unit. So I spend a lot of time in the hospital, which is pretty high stress, intense place to be as a family. And so having someone who's there periodically who you know from maybe not such an intense time, I think is really helpful to people. And so we try to set up a system where we are sort of a second supplemental team to children who may already have a primary cardiologist either at Lurie or somewhere out in the community, and to just be sort of a source of continuity for them from fetal life all the way through their transition to adult congenital care.
You touched on our CCU. Tell us a little bit about that unit here on the inpatient side of things.
So the Regenstein Cardiac Care Unit is a 36-bed unit. It's actually one of the few units in the United States that's admission to discharge. So that means that we take care of both critically ill children and children who either are not critically ill or who were critically ill and now are doing better. So you have the same sort of team of providers taking care of you from the day you get admitted until you go home, which I think is really nice for people to have that continuity, to be generally in the same room. And it's a really interesting place where there's all these different kids with a variety of different heart conditions, but I think people who work with congenital heart families know that they're sort of a unique bonded group, and so it's actually really nice, I think, many times for patients and families who are new to this process to be on a unit with other people who are going through what they're going through, and I think that's an invaluable additional source of support apart from what we, the providers, are trying to do for them. But we're also very excited that the unit is shortly going to be expanding to a 44-bed unit on a brand new floor with brand new equipment, brand new facilities. So right now we're happy with the unit that we have, but we're excited for the new beautiful one too.
Yeah, it's exciting, the growth. Just as a reminder, our viewers can submit questions live during the broadcast if they have them, and we'll get our experts here to answer them for you. Michelle, you mentioned that you care for our patients even before birth. Tell us a little bit about that comprehensive fetal clinic in the Center of Excellence, because most of our patients are diagnosed in utero before birth. How does that work?
So babies can be born, or fetuses can be born, they can be diagnosed at multiple different time points throughout the baby's weeks of gestation. And typically we'll see babies with their families sometime around 20-ish weeks or so. And that includes a consultation with the cardiovascular surgeon, the ICU, Kiona Allen, and the nurse coordinator, Mary, and the social work support, and also palliative care if families are interested in participating in that as well. And that is a comprehensive visit where we talk about what it means, what their diagnosis looks like at this point in time based on the current fetal echo and screening, and try to coordinate the best streamlined care for the baby.
Okay. But not just fetal and infant newborns we care for. We can care for children and adolescents at any point in their treatment, correct?
Absolutely. We have, we sort of, I think, have tried to be sort of a flexible model of how single ventricle care can look. So we have some kids who we diagnose fetally who follow primarily with the two of us throughout their whole life. That's actually not the most common way that this works. The most common way is that we're sort of a touch point for people at moments where you want to make sure that someone with a lot of expertise in single ventricle care is at least putting a second set of eyes on the care you've had up until then. And so we try and serve as a resource for people who, you know, there's many people out in the community with single ventricle heart disease who have wonderful cardiologists who they've had a relationship with maybe since fetal life, actually. And so we aren't trying to replace that. We're just sort of a supplement to that. So we tend to have certain touch points where
yeah, we're pointing to this roadmap. I guess I was going to bring it up, but we can go ahead and get, I guess, and then Michelle has a copy there, Kiona, if you want to look at it.
Oh, yeah, that's
too.
okay. But
yeah, tell us a little about this roadmap.
Well, I think that one of the things we've discovered is that this, well, and this is not a surprise, but that this is a whole lifetime of care, and helping people understand what to expect is helpful. And every child has a different path, and we can't always predict, you know, how long you're going to be in a hospital or what kind of complications you may have, if any. But having some idea of what's coming and what the typical course is really helps people stay grounded as they go through this process. So we start with the fetal comprehensive visit, and then most babies, although not all, will have a newborn surgery. And then they have pretty close follow-up in that period between the newborn surgery and the second surgery. The reason for that is just that their physiology is pretty fragile. After the newborn surgery, most of the children either have something called a shunt, which is an artificial tube that supplies the blood to the lungs, and that shunt is made of foreign material, so the body is constantly trying to clot it. And that can be very dangerous. They also, as I talked about, have just one pump doing the work of two. And so they're sort of a more fragile set of patients in an already kind of fragile time. Newborn babies are a lot of work, even ones without heart disease. And so that's a time frame where our team, our interstage team we call it, provides a lot of extra support for families because they're dealing with complicated issues with feeding and with medications and with trying to figure out how to have a newborn baby at home with or without medical problems. And so that's that interstage period here. But there are children who come to us who didn't have a fetal diagnosis, for example, who were postnatally diagnosed and get transferred to our system after their diagnosis is made in the newborn hospital. So that's a place where patients sometimes come in. We also have children who don't require a first surgery who are being followed out in the community by a cardiologist or by a cardiologist at Lurie who isn't part of the like tighter team of interstage care. And so they sometimes get funneled into us around the time of the glen surgery.
So once we get into the glen surgery, that's the series of 3 surgeries that's pretty standard for a patient with single ventricle physiology. But do they all have to undergo 3 surgeries?
It depends on your anatomy.
Okay.
As I was saying, every heart defect is a little bit different. It's really sort of like an infinite array of combinations of things that can happen. And so many of our children will need a newborn surgery, which we usually call a stage 1 surgery. Okay. But what that looks like can be different for each defect. So some of them have too much blood flow to their lungs, and we have to restrict that with something called a pulmonary artery band. Some kids have not enough blood flow to their lungs, and we have to add an artificial tube to get more blood flow to the lungs. And some kids are pretty balanced right from the get-go, and so they don't need a first surgery. And then children with hypoplastic left heart syndrome have a large surgery called the Norwood operation, which is what people traditionally refer to as the stage 1. But there are many different kinds of defects that require a newborn surgery. The glen surgery, almost everybody will have if they're going down the pathway of single ventricle heart disease. And in that surgery, we take the superior vena cava is a blood vessel that brings the blood from the head and the upper body back to the heart, back to that top chamber, the right atrium, as we were talking about before. But you can see that right here, this was the pulmonary artery, which is the blood vessel that pumps blood to the lungs, and that it runs right behind the superior vena cava. And so what the surgeons do is they detach the superior vena cava from the heart, and instead they connect it directly to the pulmonary artery. So once that's been done, the blood from the upper body and the head goes directly to the pulmonary arteries without first going through the heart. So there's nothing pumping it. It just sort of passively flows through the lungs and picks up oxygen. And once you've done that, actually, you've offloaded the heart. So instead of having the blue blood and the red blood both coming back to the heart, pretty much only the red blood is coming back to the heart. That's not totally true, but it's definitely less blood than there was in the first surgery. And so children many times after this surgery do much better than they were before that.
And then when can parents expect their child to undergo the glen surgery?
So the glen surgery is usually around 4 to 6 months of age.
Okay.
It depends. Every child is a little bit different, but that's usually what we tell people.
And then I noticed, and this is one of our questions from a viewer, do all single ventricle kids have to have neurodevelopmental screenings? And I noticed on the roadmap that we have a neurodevelopmental clinic. So I'm curious as to what that is, and do all kids need to undergo the screening?
So we recommend at our center that everybody does, because they are oftentimes very compromised with a long hospitalization. The first surgery, the Norwood operation, can be anywhere from 4 to 6 weeks length of stay, and that can impact development, in addition to needing the bypass machine. And so we think it's really important to assess and screen very thoughtfully throughout all course of time points throughout a lifespan. And in the baby period, there is a cardiac NICU follow-up program, and then as kids get older and transition to school age, there's another follow-up program that helps identify issues as kids go to school, and there's a school liaison that can partner with families to make sure that they're getting the best resources throughout their learning needs.
So it definitely sounds like throughout the course of treatment, these surgeries, we're not just having the patients come in for surgery, they go home. There's definitely a continuous care model that you guys are implementing with these patients. Tell us a little bit more about how, not just with the neurodevelopmental clinic, but in between each surgery, what parents and patients can expect, I guess, with treatment if they're not coming in for surgery, but what else is going on?
We reach out to the early intervention program within the state so that we can provide opportunities for families to get speech therapy or feeding therapy for those with NG tubes, supplements at home, so that kids can continue to learn how to feed in their own home environment as best possible. and occupational and physical therapy to try to partner and keep their skills up to par.
I think that I'm really glad that someone asked that question, actually, because I think that's the most fascinating part about being someone who cares for children with single ventricle heart disease. It wasn't that long ago that people were just happy that children with this survived at all. And now we've done such a great job of improving outcomes that we're not so focused anymore on the inpatient course and the surgeries and what cardiac medications you need at home. Those things are important, of course, but those things don't matter if when you're 12 or 13 years old, you can't succeed in school and you don't have friends and you don't have a good life with your family and everyone is sort of a captive to the cardiac condition. And I think that's what our team has strived so hard to help support people with. That the reason that we do this is that we believe that children with single ventricle physiology can be kids and be out in the world doing the things that kids out in the world do. And in order to do that, we have to put special supports in place to help them achieve their full potential. But that's our goal, that the families will know that the children have heart disease, but that maybe the kid down the block doesn't know that this kid is any different than anybody else. And so that's why the neurodevelopmental piece is so important, both our clinic and all the other supports that are out there in the world already with early intervention and outpatient physical therapy. But the neurodevelopmental piece is more just to make sure that things are staying on track. We know that children with congenital heart disease, not just single ventricle heart disease, but all kinds of congenital heart disease, are at risk to have trouble with school. And what that looks like everything else, is a huge spectrum. So it can range from special education classes to just needing a little bit of extra help or having a little bit of attention deficit disorder. But if we aren't being proactive about making sure that we're addressing these issues as they come up throughout children's lifespan, then we're going to be behind when they get to school, and instead of thriving, we'll be struggling to catch up. So that's why the neurodevelopmental piece is so important, and it's hard many times because there's so much going on, right? The children are on medications and they're working on feeding with an NG tube maybe, and they have more surgeries coming up, and so it's hard to focus on whether or not babies are smiling when they're supposed to and sitting up and starting to crawl and all those things. You're just happy that they're home and that they're okay, but it's so important. So that's why we really encourage people to get that follow-up, even though it seems kind of silly at the time sometimes.
No, definitely the whole child and their well-being, not just the heart, which is what we're here for. I think we have another question, or a few questions. So what percentage of your HLHS kids deal with decreased function after the glen? Is that hypoplastic left heart syndrome?
So I don't know that I have a true percentage of that. I think we know that there are some children who the single right side pump, so in hypoplastic left heart we talked about how the left side is malformed and usually either small or missing. And so they are reliant on a right ventricle pump to pump blood to the body for their whole lifespan, or at least the lifespan of that heart. And the right side pump, while it looks similar to the left side pump, in some ways, it's just not designed the same way. They actually are anatomically different. And it's not designed to pump against the high pressure of the body. The blood pressure in your lungs is usually a third or less the blood pressure in the rest of your body. And so the right side pump is designed to pump against that low pressure system. And so when you ask it to pump against a high pressure system for decades potentially, sometimes it can't do that. We aren't great right now at predicting who are the children who are going to have early failure of that pump, that right side pump. There are things that can help you know that. So sometimes we see evidence of poor pump function even in utero or early on in neonatal life, and those children we think are at higher risk to have pump failure after the glen. There are children who have a lot of leakage of the one valve that they have, and that certainly is a risk factor to have more trouble after the glen. We also know that some children do better after the glen, again, because I talked about how after the glen there's not 2-3 times as much blood coming back to the heart. It's much more a normal amount, and so that actually sort of helps the heart to recover from the stress we've put it under for the first 4 to 6 months. So there are some children who have a glen operation and actually do better, and there are others who have a glen operation and the heart function just doesn't really recover from that. And in those children we start to think about things like heart transplantation.
And the next question, is there a time frame when the Fontan should be done? Does it help if the surgery is done sooner than later?
That's also a really good question that there's been a lot of studies trying to look at the proper timing of a Fontan operation, and there's been a huge shift in the timing of when it's done over the past, we started doing the Fontan operation that we do now in its current form, sort of in the early 1990s.
And that's the last...
that's the third surgery?
Third surgery.
We haven't so much talked about that one, I suppose.
No.
So we talked about in the glen, you connect the superior vena cava to the pulmonary artery because it runs right there behind. There's also a blood vessel from the lower body called the inferior vena cava, which connects also to the right atrium. So at the time of the Fontan operation, we take that blood vessel and use an artificial tube usually. There's different ways that this can be done, but typically here, we use an artificial tube called a conduit, and we connect it directly to the pulmonary artery. So now the superior vena cava and the inferior vena cava both connect directly to the pulmonary artery, so that all the blood coming back from the body goes directly to the lungs without first being pumped. We typically do that surgery around 3 years of age. The reason for that is that we have to use the conduit, an extra cardiac conduit it's called, which is a piece of artificial tubing that is not alive. It's a synthetic material that won't grow with you over time. So we try to wait until you're big enough to get a tube in that will be big enough to last you your whole life.
And that
so
will
that's
last
why.
your whole life.
Mm-hmm.
You don't have to have it replaced.
Well, we know that children with the majority of children who have a Fontan operation will have some kind of re-intervention in their life after the Fontan. That doesn't always mean open heart surgery. Sometimes it can be done minimally invasively, like in the cardiac cath lab, where they use wires and balloons and other things to intervene on narrowings or holes that shouldn't be there. But many children after that, the Fontan procedure will need like a stent, so a wire cage to help hold the conduit open. Some of them actually will need surgery on their pulmonary arteries or on the conduit if it gets too small. Some children need pacemakers and other things. But the goal is for that tube to be big enough that it theoretically could last your whole lifetime. We also know that, particularly for children with a single right side pump, we're not sure how long that pump can last. Can it last a whole lifetime? We don't know, because we didn't start doing this Fontan operation until the 1990s. So the people who had that are only now approaching 30. So we don't really know what will happen to them after that. I think most of us in the field believe that in most cases, the single right side pump in particular probably won't last you until you're 80 years old. But how long it can last with the advances that we've had in medicine, I don't think we know for sure.
And with the Fontan, the saturations tend to step up a little bit. So you and I are, closer to 99, 100% for saturations. With the first surgery, the Norwood or any kind of shunt, saturations are expected somewhere around 75 to 85%. At the Glen, it's pretty typical. That will stay the same, 75 to 85%. And at the Fontan, they step up into the 90s.
We have another question from a viewer. Are other structures affected by these pathologies?
I'm not sure. Do they mean other organ structures?
Distal blood vessels is an example.
So I think that's kind of an interesting, there's all sorts of we've been very focused on the heart and congenital heart disease in general. How does this affect not just blood vessels, but all the other organs? I think that is an area that we've become more focused on over time. Obviously, we're focused on how does it affect the brain. I don't think we know for sure, for example, people without congenital heart disease have things like coronary artery disease and peripheral vascular disease and things that adults get. And our children are just now becoming those adults. And so how this will affect the things that regular people get, I have no idea. I think that's an area that we're all very interested in, and that we'll need to encourage our kids to be heart healthy the same way we encourage everybody else to be with exercise and eating healthy and all those things. There's also, for the most part, the blood vessels in your hands and your feet and deep down in your legs are pretty normal. It's mostly just the major blood vessels in the chest that are usually affected. The blood vessels in the brain usually aren't anatomically affected anyway. But the blood flow to all of those places is not normal. The blood flow to and the blood flow from. So that can definitely affect, we talked about the brain already, we know that the kidneys can definitely be affected, the liver can definitely be affected, the intestines can be affected, and the lungs probably can be affected too. And so those are all the other things that we have to watch for as we follow kids medically with single ventricle physiology to make sure their other organs are doing okay and that we're putting things in place to help protect them.
Another question is, Lurie Children's looking into doing or working with stem cells to help children with HRHS. What is HRHS?
HRHS is hypoplastic right heart syndrome. That's such a great question. I wish that Dr. Epting was here to talk about the Fontaine Futures program.
That's on our website, so I can actually post more information about it in the comments after the broadcast. But
so stay tuned about that. We do not currently have an internal cord blood banking program or things like that with stem cells specifically. There are researchers in Northwestern and in the Stanley Manning Children's Research Group that are working on stem cells for cardiac disease, but we don't currently have active clinical trials or things like that in that area. But it's something that people are very interested in.
And I will definitely post a link to more information about that after the broadcast. Okay, so let's talk about after the third surgery, what happens? You're probably reaching, adolescence. Do we care for adolescents? I know they transition into adult care. How do we manage that transition as they've been here, probably some of them since before they were born? What does that look like for our patients and families?
We absolutely care for adolescents, and that's a really important time period where a lot of things are going on, where the adolescents need to start to learn a little bit more ownership of their care and partnering with their parents and partnering with us. And we do still care for adolescents here in the clinic, and also if they need inpatient care. And we are very fortunate to have a great adult congenital team here that also cares for single ventricle patients as they transition from the adolescent period into early adult time points.
So we call that the cardiovascular bridge program, and so the idea is that there's actually, instead of a transition, there's an overlap where they're being cared for both the children's team and the adult congenital team simultaneously. And so we partner very, very closely as we're starting to transition children so that when they fully transition, they'll already have been followed by the adult congenital team for a period of years even before that transition happens. And so we try and start thinking about that when kids are reaching 16, 17 years old, and the overlap typically is several years long, so that it's not until you're 21, 22, around there, that you start to move all the way into the adult congenital program.
Okay. Then you mentioned, Kiona, it wasn't until really the 1990s that we had one of these surgeries even possible for these patients. How has treatment changed, improved? What are some of the advancements that you guys have seen, even in your practice, over the last few years for these patients?
I think the biggest thing is just paying attention to the details, the important details, and not letting anything slide, and continuing to focus on the resiliency of patients and families, because honestly we're doing all this because we want them to be functional children and young adults and transitioning into a great outcome.
Yeah, I think that and more sort of national and international collaboration about these kids, because no one center, even a huge center like this or some of the other large centers in the United States, has enough patients to do really big research studies the way that adults are fortunate enough to be able to do. An adult study of coronary artery disease has thousands of patients in it, and usually with a multi-center study for congenital heart disease for any specific condition, you can't get more than several hundred children. And so it requires us to collaborate with our colleagues across the country and across across the world, actually, which has been, I think, good for kids and good for us, that there's no reason why something that's working some other place shouldn't be expanded and rolled out to the rest of the community so that we can all be moving forward together. And so we're part of several large collaboratives. The one we use the most often is called NPCQIC, which is a national collaborative that focuses primarily on children with hypoplastic left heart syndrome, but is moving more and more towards working with all children with single ventricle physiology. And they've put together sort of a best practices that have been rolled out to many centers. There's, I think, 60 centers that participate in NPCQIC. And with that, we've been able to actually improve the mortality for children with hypoplastic left heart syndrome, at least in that high-risk interstage period. So I think we're all very hopeful that continued collaboration will continue to have results like that, where we aren't just collaborating, but we're actually making a huge difference.
And changing the course of treatment and outcomes for these kids.
Yeah. Right. And I think the other piece is advocacy. Like, there's a huge there's a huge array of different advocacy groups out there to help support patients and families and providers throughout this experience, because nobody can do it alone. And I think that's a big piece that is, changed in the last several decades, is importance of, recognizing that congenital heart disease is the #1 heart disease, and is still really very underfunded. And until we keep sharing our stories and keep making that message, we're not going to change outcomes. And so paying attention to that, advocating with your local representatives, and making that message known so that we can transparently move forward and change outcomes for the future.
We have some more questions from our viewers. First one, are there any additional risks with the surgical procedures due to having only one functional kidney?
So that question is a little bit specific, and it's hard to answer. Like, there's a lot that goes into deciding whether or not that's the case. I guess I would say, in general, having problems with your other organs certainly can increase the risk of surgery and of having one of these conditions in general. It sort of all depends on how affected those other organs are, but having kidney dysfunction, having other congenital malformations, all of those things are known to increase the risks, yes.
And then another question, are there any instances where a single ventricle patient couldn't have a Fontan procedure or heart transplant?
Yes, there are, unfortunately. I think I would divide that into, that's sort of two separate questions. So first of all, at any point down the pathway that we've talked about, it can be the case that you're not still a candidate for single ventricle surgery. We're setting up a circuit, a circulatory system circuit that is very abnormal. And so the conditions that need to be met for you to be able to have that circulation are very specific. Because since the blood has to go passively through the lungs, the blood pressure in the lungs has to be really nice and low. The blood has to move through easily because there's nothing to pump it. And so if you have problems with your lungs, if you have problems with your blood vessels in your lungs, if your heart function is quite poor and the blood backs up and causes high blood pressure in the lungs, all of those things can be reasons that we can't move forward with single ventricle surgery. The main reason why we wouldn't do it is because it won't work, and we would be causing harm as opposed to saving lives. And so there are definitely cases where the physiology of the baby or of the child is no longer acceptable to move forward with those surgeries. When that's the case, the first thing that we do is talk to parents about decision making and goals, because the only other sort of real option for long-term success, if that's the case, is to do a heart transplant. But a heart transplant isn't something that every family wants, and that's okay. And so we have conversations about whether or not that's the right thing for that family. And there's a whole process that goes into evaluation for transplant, because not all children are candidates for it either. So you have to be healthy enough to get it as well. And there are some reasons why, first of all, children with complex congenital heart disease are higher risk, period, for when they get a transplant. Their outcomes are not as good as children who get a transplant who don't have other medical problems. And so that's a checkbox that we already have a problem with, but many times we're still able to do it. We just have to do a very careful evaluation to make sure they're a candidate. And the details of like what those boxes are that you have to check are pretty complicated, but our team works really closely to make sure that if it's something the family wants, that we would take that risk on if we think that there's a good chance of success. But there are some cases where doing it would cause harm, again, more harm than doing nothing, and so in those cases we have to make the difficult decision not to proceed with that. So that's a complicated question, but it does happen. Fortunately, not super often.
And when you move into that transplant world, you're sort of trading one disease for another, single ventricle, and now you're changing into the like it's not
an
easy, it's not an easy equation to transfer.
Right.
We don't have a cure for this problem. Right. We have a lot of ways to work around it. And that's true for a lot of different conditions. Right. And so I hope that in the long term what we're looking at is a way to manage children with single ventricle congenital heart disease like you manage someone who has diabetes or any of those other problems that children are either born with or develop over the course of childhood and have to work their way through. This just happens to be one that you often know about before they're born, and so you have a lot of opportunities to plan and to think. But like all these other conditions, it's a lifelong commitment, and we're making a lifelong commitment back.
Right. And another question. What is the percentage rate for hypoplastic left heart syndrome patients to reach adulthood? Do you know who is the oldest person with hypoplastic left heart syndrome?
That's an interesting question. I actually don't know
the
oldest person. I do know, so it's hard to, there's not a lot of studies looking at babies with hypoplastic left heart from the time they were born all the way through the end. Part of what's tricky whenever people talk about numbers is that in order to, if you're doing a study looking backwards, which is what we usually do in congenital heart disease because there's not that many patients, in order to know what happens to people who are 30 years old, you have to look back at people who had surgery 30 years ago. And is that the same as having surgery in 2017? Probably not, but how different it is hard to know. So I think we believe that the outcomes are probably better than they were for people who had surgery 30 years ago, but we don't really know that for sure, and we can't say by how much. What we do know is that the mortality for example, the Norwood surgery, which is the first surgery for hypoplastic left heart, is something between 10 and 40%, depending on where it's being done. But I guess we usually use the number 10% at most of the high volume centers. The mortality between the first surgery and the second surgery is somewhere between 5 and 10%. The mortality for the second surgery itself is something less than 5%. So you've already gotten to about 25%. And when we look at, there was one study done of children with hypoplastic left heart from the time they were born all the way through. I think they've now published the data up through about 2 or 3 years of age. And those children are mostly doing okay, but something like 70% of them are alive with their same heart. So that means that 30+% have either had a heart transplant or have passed away. That goes up past the Fontan time. When you look at just children who had a Fontan operation, so forget about all those other numbers, all children who have successfully had a Fontan operation, we know that at about 25 years of age, about 70% of them are still alive with their same heart. So it's like 70% of 70%. Right. But again, in order to get those numbers, you have to go back to people who had surgery a long time ago. And so I don't really know if you have a baby born today. I can't tell you that they have an X% chance of being alive with their same heart at 25 years of age. But it is I hope, I have to believe as a doctor, that we've moved medicine forward quite a bit since 30 years ago, and that hopefully the outcomes are even better for children who are being born now.
I think just to give a little perspective, Kiona talked about the NPC-QIC collaborative, and that collaborative partners with parents and families and actually keeps them as equal partners at the table, which is amazing. And at that collaborative, there are several patients themselves who are equal collaborative partners in their 20s and 30s. And, you know, which is amazing, you know, that and living quality lives. Like one is a cardiology fellow, and one is a PA who is scrubbed in on every single one of those surgeries, which is amazing.
We have one more question. I think after this we're going to wrap it up because you guys have patients to see today. How long does the glen last, and I guess at what age is it performed, or at what age, I guess, would you move on to the next step in the process?
I'm not sure how, are they talking about the length of stay?
I don't know. I guess that the glen surgery in general is a less, it's usually better tolerated than, for example, the stage 1 Norwood operation. So the length of stay is usually about 2 weeks. The glen surgery itself is done usually between 4 and 6 months of age, and how long it lasts is different for each child. We typically will go ahead and do the Fontan operation at 3 years of age because around that time we're able to get in the right size artificial conduit, and so there's not necessarily a reason to wait. But not all children who are 3 years old will need a Fontan operation right then. We usually do it out of convention, but typically, like, there are some children who are 6, 7, 8 years old who still have a glen, depending in particular on their specific anatomy. But there are also some places, not many, but some, that believe that you should stay with a glen unless there's a reason to do a Fontan operation. We know that not having the blood from the lower body going to the lungs can cause problems to the lungs. There's special like hormones and other things that the liver makes that the lung needs. And so when you don't do a Fontan operation, the blood from the lower body, including the liver blood, goes into the heart and then gets pumped right back out to the body. And so over time, that can cause problems in the lung that are reversible. Once we do the Fontan operation, those problems go away. But some places will not do a Fontan operation until they see evidence of the lung problems that you get from not doing it. So there's not really an end point to the glen. There are children who are much older who still don't have a Fontan operation yet, but most places will just go ahead and do it at 3 years of age because they can.
So lastly, I know we touched upon it, the outcomes, but what are the futures like? What do they look like for your patients? Or what do you hope they look like?
I am very hopeful, and that kids will, grow up, participate in school activities, typical activities, and join families, and I mean, honestly, it's endless, the hope that I have for these patients and families.
I think we have been very fortunate in that the way that we sort of become integrated in these families to really be able to see the life that we're helping kids to have, from, a high-risk interstage patient on a motorboat wearing a life jacket with his feeding tube in his nose. We have a picture of that. Yeah. We have a girl who has a number of Fontan-related complications, who performs in her school show. I mean, our children are children. Yeah. And it's nice to be a part of that. So that's what we hope for, that they're going to be out in the world doing amazing things.
I think we'll leave it at that. You guys are truly making a difference, and I thank you so much for taking the time this morning with us for the first Lurie Children's Heart Center Facebook Live. Thank you.
Thank you for including us.
Yeah.